So this morning we have presentation from Traci and Jenna and Alicia. I sent their bios on the agenda, but I will read a quick abridged bio for Traci, Jenna, and Alicia, and then they're going to get started with sharing their screen. They were kind enough to say that their slides will be shared, so I will be able to send those when I send the meeting minutes in the next couple of days. So welcome all. I appreciate this. And to get started, we have Traci McComiskey, the founder director of Birth Support Education and Beyond. It is a comprehensive home visiting program serving the highest risk youth, young adults, and women in recovery in Connecticut. Traci's been working in direct patient client care for decades and with the past 20 years focused on maternal, infant, family care, and wellness. She's a certified labor and postpartum doula, childbirth and parent educator, and retired midwife and former doula trainer. Jenna Cohen, Jenna, wave, hello, Jenna. Jenna Cohen is a clinician specializing in infant loss. Jenna is a licensed clinical social worker in Connecticut and specializes in grief and loss, traumatic complex grief, child loss, infant loss, pregnancy loss, spousal loss, and sibling loss. And perinatal mental health. Jenna holds advanced training in perinatal EMDR, as well as training in expressive arts therapy and perinatal mood and anxiety disorders. Welcome, Jenna, and thank you. Alicia Johnston, hello, Alicia, is a person with lived experience. Alicia Johnston has served as the program manager for Hope After Loss since September of 2020. Hope After Loss is a Connecticut-based nonprofit serving the pregnancy and infant loss community through various support and education programs. Alicia is a social worker earning an MSW and bachelor's degree in art therapy from Anna Maria College, focusing on community research and social advocacy efforts. The Connecticut Women's Consortium and DEMIS welcomes all of you, and we thank you so much for sharing your expertise with our group this morning.
Thank you so much for having us. I'm going to share my screen here. Is everyone able to sort of see that? Well, I just want to make sure we don't have any hiccups to start off with.
Yes, Traci, it looks great.
Great, thank you. So thank you for having us. We wanted to just sort of be mindful of perinatal grief and loss and take this opportunity to sort of honor and respect those that have experienced this and just bring some awareness to a conversation that's not often held or for, a topic that's not really talked about very frequently. So I'm going to skip over this slide. You guys have already heard a little bit about who we are and where we're from, thanks to the introduction that we had. Again, we're here to honor and support those that have experienced grief and loss in the perinatal period. The discussion that we're going to have can sometimes be a little bit triggering, and I want to just make sure that I'm very mindful of that. And if anybody needs to just sort of take a moment to pause, take a break, please feel free to do so. You'll also have time that we'll have a further discussion at the end of the presentation. Any questions or comments, feel free to use the chat and we'll get to those as well. So I think first, in order to talk about pregnancy loss and infant mortality, we have to really talk about the prevalence. Overall, in the United States, the rates of loss have seen a bit of a decrease, but when we do comparative countries, we are actually still standing at some of the highest rates of infant and maternal mortality compared to other countries. We define miscarriage as a loss before 20 weeks in gestation. So it's estimated about 10 to 20% of known pregnancies end with miscarriage each year. Stillbirth is defined as a pregnancy loss after 20 weeks in gestation. And every year, about 21,000 babies in the US are stillborn. Infant mortality is defined as infant death from birth to age 1, and we have a rate of about 5.6 per 1,000 live births every year that are ending in infant mortality. We really want to just be extremely mindful too that part of these numbers are significantly impacted due to racial disparities, health inequities. For instance, non-Black birthing persons have about double these incidences of pregnancy loss, infant and maternal mortality compared to white birthing people. We really have to do better just as a whole. We have to do better in maternity care. We have to do better in health equity.
Traci, is it okay if I jump in on that last slide for a sec?
Absolutely.
Thank you. So something I always like to do, if you don't mind going back to the slide before, is because sometimes I look at these numbers and I'm like 20%, 10%, it doesn't really mean that much to me. But when I think about if you're sitting in a room of 20 people, right, that it probably one of those people, at least one of those people has experienced a miscarriage. If you're at a concert, right, with 1,000 people, right, 5 to 6 of those people will have lost an infant, will have had an infant that have died, right? And what is it, 200 people will have experienced miscarriage. So I just like to give, I don't know with the last concert or the last big event you went to, why it's so important that we talk about this, because it's not talked about. But if you're in a room, a big room full of people, how many people have experienced and been touched by perinatal loss, and sometimes multiple losses? Thanks, Traci.
Yeah, thanks, Jenna. So we use the term perinatal loss as loss of pregnancy at any stage in gestation. And that includes when a pregnancy hasn't been confirmed more than with home testing, or even if there is no presence in the growth of an egg sac during an ultrasound. These are still periods that are worth, worth noting and worth grieving, even though typically in society, we just don't think about those periods of time as somebody that can experience perinatal loss. So I really want to sort of broaden the way that we think about perinatal grief and loss to use a much larger lens. People can have experiences in which they can still feel loss. And those times can be times that I've listed here. It's a pretty busy slide, so just bear with me. I'm not going to go through each and every word here, but with infertility, oftentimes there's these repetitive cycles of hope and loss, hope and loss. From conception, whether it be miscarriage or termination or stillborn or neonatal death. In fetal testing, we can sometimes find that during fetal testing, there might be a concern that's seen, or an ultrasound shows something that needs further testing. That can also be a time of, when a birthing person is experiencing an array of emotions and concerns, during unplanned, unexpected outcomes, due to stigma, biases, predictive parental inabilities, especially in persons with mental health diagnoses and histories of substance use disorder, trauma, teens, people experiencing health inequities. These are often times where there are judgments going into the birthing experience, or even in the prenatal period. There's prejudgment of biases, and that can also change the way somebody's experiencing that prenatal care and how their birthing event can happen. When there's DCF involvement, a temporary hold gets put on a baby. A birthing person has to leave the hospital without their child. Sometimes they're being placed with these safety plans with lots of steps that they have to be monitored, watched, and be accountable for and achieve. Even in breastfeeding, whether somebody's struggling because it's medically contraindicated or they're choosing not to, there can be judgments and stigma around that. In the adoption process, with foster care, And, with incarcerated women too, who are birthing and they don't have any known supports that are attending with them. So usually they're not able to have a family member join them in the birthing process at the hospital. They often will have a corrections officer standing either in the room or outside of the door. We've come a long way. There are labor coach programs and supports in place, but sometimes they don't have access to those people that are going to support them in the prenatal period. So they're met while they're in active labor, admitted to the hospital with who their support person is going to be. So again, these are just times where people can experience unexpected outcomes. And we want to really think about that as being a time of perinatal grief and loss as well. So for many families and support people and even providers, sometimes it can be really uncomfortable to sort of know what to say, how to say it when somebody is experiencing perinatal grief and loss. So when a baby dies, a parent is emotionally vulnerable and sensitive to words that we use. It's important to show compassion and validate their grief without inadvertently being insultive or adding to. The use of medical terms such as fetal demise or blighted ovum really sounds kind of cruel and can make a parent sort of feel that their experience was a medical event instead of an actual loss. We want to avoid euphemisms such as like passed away or gone to a better place. That can often be felt to be dismissive, and some parents have even reported that that's pretty infuriating when that's what they're hearing. Their baby hasn't gone missing. You can't really compare losses either. There's not one loss that is more significant or less significant than another. If a person is experiencing loss, they are experiencing that, and we have to validate that, and we have to really help them to process and move through the steps. We want to avoid things like it's going to be okay or time heals. You can have more children. Some people with well-intention will say, well, at least your baby is in a better place. And if you would have had this baby, would have been very sick if they had lived. Well, I'm glad you can get pregnant again. That's important. And faith-based statements often don't go well, such as it must be God's will or they're with the angels now. There's a whole variety of things that, parents have reported that really cause more hurt rather than support.
Traci, is it okay if I just jump in on awesome? So, and I think what happens with a lot of those words, it's because people don't know what to say and they're actually trying to make themselves feel better. It's an uncomfortable situation. And often when we don't know what to say, we want to say something to make ourselves feel better that might make the other person feel better instead of actually acknowledging and being in the grief. So sorry, Traci.
No, thanks, Jenna. That's a great point. So now we've sort of discussed, what do we want to avoid? So I want to just mention, like, what can we use? Many of us know, especially that work in the fields that we all work in here, many of us have a good sort of, framework to use supportive language. But I like to just throw some reminders out there. It's important to say, yes, of course, this hurts. And this is grief. And you're not alone. I see you. I wish this hadn't happened to you, or I'm so sorry. It's also important to say, I'm here to listen. Just tell me where you want to start. And you can also completely admit, like, you don't know what to say right now, because oftentimes we don't, especially if it's an unexpected outcome, something that was just, not seen in the prenatal period, not anticipated. And I like to ask, like, what would be helpful for them? What can I do to help support you right now? And sometimes there's nothing. You're not going to get an answer, and that's okay too. And if you don't know what to say, just remind them you just want to be there for them. So as doulas and birth workers, support people, how do we support a person that has a known, stillbirth or a known fatal diagnosis in pregnancy? How do we help them during that birth process? We want to provide them with informational support, educational support, but we just want to also be there in the capacity that they need it, which may be uncomfortable and it may be unfamiliar. And we're going to talk a little bit later on about how to support yourself during periods of this, because that's important as well. But for the family that you're with, it's important to sort of acknowledge, like, this is an uncomfortable time. We want to assure as much time as they need, how they define it with their baby. Really want to encourage that skin to skin, cuddling, even bathing, diapering, and clothing whenever possible. We want to normalize their birth experience. Hold space. Don't just sort of say, okay, well, we're going to leave the room and let you guys be alone right now. It's okay to sit in a corner quietly and be there in case they need your support. You want to reassure them that their baby was not alone, that they were with them when they did were birthed and when they did die. You want to provide or help create a keepsake box, such as pictures or handprints, sometimes a locket of hair or the baby's blanket or the crib card even, and gather that and put that together. Ensure that there are spiritual supports available, help access that for them, and offer resources with, gathering information on any memorial or ritual services that may be important to them. Everybody has a different way in which they grieve. Everybody wants to, try to offer maybe knowledge of how to access this or that, or, well, we know this might be a little bit better than that. But again, we have to hold the space for the individual person and the individual family. This is, this is their experience, and anything that we can do to be supportive is important without sort of throwing in our own judgment on that. I've had experiences where there's been concern with a mom that roomed in during her hospital stay with her babies after they had died. And the rooming in process lasted for 4 days. And that was really difficult for not only support people that came to visit with her, but also for staff at times that weren't really sure, is this becoming a mental health crisis or is this normal? And, it was a normal process for her, is what she needed. And, with everybody's collaboration, she was able to sort of go through her process. And she's doing very well at this moment in time, even though she had experienced such a difficult loss of her twins. So if you know that there's going to be a difficult outcome or that there's a person, it's something to consider utilizing a doula. A bereavement doula is a doula that's had additional training in loss and recovery and specific ways to help families that are going to experience this and that are experiencing this. Traditional labor and birth doulas often are also trained in ways to help prepare families and be supportive during labor and birth, and also with connecting to a lot of different community providers and support of people that can help during this time. And I think, Jenna, you had a client that you were working with, or that you are working with right now, that you wanted to just mention.
Yeah, sort of giving a real life example of how working with a doula for someone with a history of loss has been and is continuing to be very supportive in her mental health, in her functioning, and in her processing. So I have a client who has a history of miscarriages at different stages, right? So at different stages of gestation. So going into this current pregnancy, there's a lot of anxiety, understandably, right? Of, am I going to lose this pregnancy, this baby? What will it look like when it happens? Will it not happen? Will I continue to be pregnant? I'm happy to say, and she's happy to say right now, she is over 25 weeks pregnant, but the fear every single day is still there, right? And the hope is that she's going to deliver a live, healthy baby full term. But at about 18 weeks, we decided collectively together for her to start working with a doula because she didn't know what the outcome, and no one could predict what the outcome was going to be like, and feeling every single day like she could lose this baby and she didn't know what it was going to be like. And the experience of having a doula who she knows is going to be there for her no matter what the outcome, whether she goes full term and has a healthy baby, whether she has a late term miscarriage in the second trimester or preterm labor in the third trimester, right? She will have someone that will be there with her every step of the way, right? That is not just going to talk medical stuff, right? But it's going to help her with all those supports that Traci talked about, right? And who's going to be there, witness this fear with her, witness this grief with her. And also knowing that hopefully, right, she delivers a full-term healthy baby at that time, there will also be an additional reemergence of grief of the pregnancies and the babies that she talked about that she lost. So there is someone who's going to be with her and who knows how to support her at every step of the way. So it's really important in my work to refer to people with doulas who can be supportive no matter what the outcome, and know how to help.
Thanks, Jenna. So what do we do when we're with a family and now they have to experience returning to home, getting discharged from the hospital, leaving without their baby in their arms? We want to talk about what that process looks like. We want to talk about, they're probably, if it was later in pregnancy and they were anticipating, bringing the baby home with them at that moment in time during the full gestational period, the car seat may still be in the car. What might they see when they get home? Have they already had sort of a baby shower or an event where lots of things are gathered and the home is already prepared to bring a baby with diapers and a crib or bassinet? So you want to talk about all of the things that may or may not be already in place. You want to make sure that they have food in the fridge. Do they have clean sheets and towels? Is there ample supply for, nursing pads or any of the personal care needs that the birthing person may have at home already? We just don't want to allow them to sort of go home without having the tangible items that they need, not to speak anything of the emotional support that they're going to need. You want to ask, who's at home? What does that look like? Are they going up flights of stairs? Do they have siblings that they're going to need some support in trying to explain what's transpired? It's important to make sure that well-intended family and friends don't clean out someone's house before they arrive home. It's a process that families need to really do on their own time. We want to make sure we're providing a really good list of support providers, because you want to talk about their emotional health, and there is higher risk for perinatal mood and anxiety disorders. We want to talk about plans before they leave the hospital for spatial family planning, use of contraception. These are things sometimes that do take place at the time before they're discharged. They may get a depot shot or something along those lines. So there's not an unintended pregnancy while they are just in the realm of trying to think about, well, now what? Now what do I do?
And Traci, to jump in, right? So when we think about people returning home from the hospital, without their babies or not being pregnant, we want to remember that people are often in shock. They're traumatized. They're in the throes of grief. They are dissociated, disconnected. And so the more that we, all of us in this room, right, as providers and caregivers in this work, right, that we can remember that, and we can give them things in writing, and the space, if we have space to check back in, because I can promise you, if someone walks into that hospital room and gives them information, they're probably not going to remember anything, right, because their minds and their bodies are completely somewhere else, right? So I always reiterate, the more we can give in writing, right, and the more we can follow up, the better help that we're going to be able to be.
Yeah, important points. I often like to put a list of providers on the refrigerator with a magnet so that they can just sort of look and see it tangibly, easily found when needed. You want to prepare for what are the physical changes that are going to happen. Are they going to be recovering after a surgical delivery or a vaginal delivery? Their breast milk, when is that going to come in? Are they going to be engorged? What do they want to do? Do they want to donate to a milk bank, or would they prefer to sort of dry up their milk and get some help in aiding in reducing the milk production? And how their body's going to change, how the belly's going to disappear. When you're first in that postpartum period, you still have a belly. It still appears as if you are pregnant most of the time. Want to talk about, as I said before, the risk for perinatal mood and anxiety disorders. And it's not just with the birthing person, it's with their partner as well. We want to also remind them of the importance of following up with their OBGYN or their medical provider. This is oftentimes an appointment that has been skipped. And one way that as a doula, sometimes we'll call ahead for that 6-week postpartum visit or the 2-week check-in visit and say, listen, can we make sure that we do this at a time where maybe it's at the end of your morning, appointment schedule, or at the end of your day, so that the person that you're supporting isn't going to walk into a room where other birthing people may have their newborn babies with them because they're waiting for their postpartum visit as well. So the little tiny things can be really helpful in preparing and supporting. So I feel really passionate about this topic. Perinatal mood and anxiety disorders, we know, can strike during pregnancy, anytime in the postpartum period. They can last even up to 3 years now, some of the data is showing. I would love to see universal screening tools being used for anybody that does home visiting with any families that they're supporting during any time in the pregnant, birthing, and parenting periods. We know that using these tools, is one step, but what do you do with the information if you found that you've got positive results? So having a toolkit it would be recommended, making sure you've got an established relationship with maternal mental health clinical providers, community resources, so that if you do find that somebody is screening positive, you can help them get early access to treatments. So having those people already ahead of time, sort of in your toolkit, somebody that knows you when you call to say, hey, I'm with a family now, we need some support, then you've already established that relationship. Knowing what to do with a critical screen, and that's usually when there's an endorsement of self-harm. I have an example of the Edinburgh postnatal depression screening tool up, and on question number 10, it asks about thoughts of self-harm. So as a home visiting program, as doulas and perinatal support specialists, we will not leave a family if somebody screens positive. So it doesn't matter what's on your day for the day. If you have somebody that endorses thoughts of self-harm, we have a protocol in place where we'll access for clinical support if they have a clinical team already in place, or we'll call mobile crisis or emergency services. We can also make sure we leave them with the suicide crisis hotline. There's also a national maternal mental health hotline. Very important as non-clinical providers to make sure that you get a clinical assessment before you leave a person. We don't want to leave them if they're having active thoughts of self-harm or harming someone else. There's some links at the bottom of the page here too that you guys will be able to access some of the most commonly used tools. The Edinburgh is the most widely used tool for PMADs. So Jenna, I'm gonna kick this over to you. Thank you for hearing my portion of things, and I'll pick it back up when you and Alicia are done.
Thanks, Traci. So I'm going to be talking about the more clinical supports and clinical portion. But before I do that, because there's a lot of numbers, names of diagnoses, right, facts and things, before I do that, you know, that's kind of it's important, but it's not why we're really here, right? We are here to honor the pain and the loss, right? And so what I'd like to start with is sharing many of the words, the real words that I've heard from people who have experienced perinatal loss. My baby, my baby, my baby. My baby is missing. My baby is supposed to be here. I'm supposed to be pregnant. I was supposed to deliver my baby today. Did my baby suffer? There was so much blood. I carried a dead baby in my stomach. What if this baby is dead too and I don't even know it yet? I won't survive this again. I want to die if my baby dies. I need to go back and fix it. It's all my fault. I can't stop crying. I can't cry. These tears are too big for my throat. I will drown in them. I feel so alone. No one else gets it. Why is time still moving when my baby is dead? I never got to meet my baby alive. I wonder what my baby would have looked like. I didn't get enough time with my baby. I failed my baby. I failed as a mother. I failed as a father. I failed as a parent. It's all my fault. I was supposed to protect my baby. My body failed me. I am broken. I can't look at my body. I still look so pregnant. I don't want to live without my baby. I'm supposed to be with my baby. Why did my baby die? I will never become pregnant. I will never be a parent. This pain is too big. I can't take this pain. This pain will kill me. My entire body aches for my baby. My heart hurts. My heart is too broken. I was supposed to protect my partner. I don't know how to help my partner. I failed him. I failed her. I failed them. I failed my baby. My baby, my baby, my baby.
Very powerful, Jenna. The silent thoughts that go through the minds and, and the people that are experiencing perinatal grief and loss. Thank you for that.
Thank you. And so I'm going to now move in, right, Traci, you can click to the next slide whenever you're ready. So I want to hold, it was really important to me to read all of those thoughts before we move in, because that is the thoughts, the feelings, the experience, and that's just some of them, right, that are behind all of the stuff we're going to talk about. Why someone comes, right, to get clinical support, why someone comes to therapy to help with that pain that they're experiencing. So I want to start by talking about what types of losses happen, right, when a baby dies or a pregnancy ends. So from a clinical perspective, right, there are multiple losses, right? We work with the present, the current loss, the miscarriage, the stillbirth, the neonatal death, the loss of a child, right, the infertility, but there's also that future, right, that loss of what was I going to be like as a parent? what was it going to look like when I nursed this baby, right? What was it going to look like when I dropped them off at daycare and they go to college? What type of parents were we going to be together? How was I going to do that single mom or dad parenting, right? So there's all these past, present, and future, and it also brings up a lot of past losses as well, right? I was supposed to be a mother or a father like mine, or a parent, right? And it brings up losses from childhood. So we're kind of holding that time kind of melds in on itself when we have all this past, present, and future loss together. And also holding, right, that perinatal loss, and Traci talked a bit about this, is often a disenfranchised grief, right? And how does disenfranchised grief, how does that impact the experience of grief, and how does that impact someone's mental health, right? So often, like, so what is disenfranchised grief? It's grief that there's no space for. It's grief that's not validated, right? So people may hear things, there's often a belief in our society, and people may hear, right, that the loss is easier. An earlier death, right, is easier than the death of an older child, right? Or that it's not acceptable to talk about pregnancy loss or infant loss or stillbirth, right? And that it won't be acknowledged, right? There's also not the same established standard of care, not the same standard traditions to memorialize and to move through that grief, right? And all of this, right, can lead to isolation. So if you have someone who was 14 weeks pregnant, 32 weeks pregnant, 40 weeks pregnant, right? And they still look pregnant, right? Because they've lost that baby, lost that pregnancy, and they go out into the world and people still think they're pregnant, right? But either they're scared people are going to talk to them, or they can't talk about it, or they're not allowed to talk about it, or people don't know what to say, right? They're going to isolate. And this happens all the time, right? And we know that isolation often leads to increased symptoms of depression, anxiety, and other perinatal mood and anxiety disorders, which I'll get more to in the future. So Traci, we can go on to the next slide. Thank you. So I want to talk a little bit about the grieving process too, right? And I often hear this in real life and from clients as well, is I don't know how to grieve this. There's supposed to be some right way to grieve, and how do I grieve? Well, we know there is no right way to grieve, right? There is no actual path of how to grieve, right? And grief is a natural part of life, as much as in this society, right? The society celebrates life and it celebrates health, right? But just as much as life and love is a natural part of our world, so is grief, right? And grief is a natural response to loss. Grief is an active state. It's a verb. It's not a noun. It's not a stagnant thing. And there's a lot of frameworks out there, right? As therapists and as humans, to help us understand the work of grief and the process of grief, right? So most people here have heard of the Kubler-Ross stages of grief, which wasn't actually originally created to talk about the grief process of losing someone else, but I'm gonna use it because it's a well-known stages of grief that we talk about, right? So there's anger, there's denial, there's acceptance, which I like to call adaptation, because acceptance can often trigger stuff, right? But you notice there's all these different feelings and emotions, right? And we know it's not linear, right? It's more of a roller coaster or a spider web, right? Of feeling, you can have multiple different feelings and be in multiple different stages at once. So it is not a stagnant process. It's very, very active, right? There's also, there's a framework called the dual process, right? Where people move from loss orientation to restoration, right? So people will often go from that very, very active stage of feeling that loss, right? To back and forth to another stage of, okay, how am I adapting to that? What is my day gonna look like? How am I gonna make meaning? What am I gonna do next? And going back and forth, and also doing both at the same time. There's also Niemeyer, who's someone who works very actively in the world of grief, right? He talks about the importance of meaning making in grief, right? And what does that look like? And for some people, that can be certain rituals. For someone else, that could be advocacy, right? To help prevent SIDS or to raise money, right, for certain foundations. So that's a way to bring meaning. For someone else, it could be writing a piece of music or finding a song, right, that every year they listen to on the anniversary of the loss of their pregnancy or their child's death. So there's lots of different ways, but again, it's this very active state. And so often what happens when people come to me, right, for clinical support is because they're getting stuck in their grieving process, right? And it's maybe stuck in this state of disbelief. And if I could just go back in time, if I could just go back in time, if I could just go back in time, right? And there's no adaptation, right? Or the feeling of, I don't want to live without my baby, right? It stays and it stays. And there's no fluctuation between, there's times of the day where I don't want to live without my baby. And there's times of the day where I can feel that, but I can also find meaning and ways to make meaning in my life. So that's often when people come to me, they come to me at a point where I can't take it anymore, right? Because they're often stuck. And as an EMDR therapist, that's what I often work with when people find themselves, and it could be stuck on a thought of, it's all my fault, it's all my fault, it's all my fault, it's all my fault, right? And so we want to, and clinically, we want to help that person process their grief and continue to move through all the different stages and all the different feelings that they need to. Something I like to tell people, and that I truly believe, right? People often come in so overwhelmed by the intensity and the depth of their grief. And so I like to say that grief and love are the flip side of the same coin, to help people understand and say, why is this so painful? Why can't I just move on, right? And I say, well, how deep did you love? How deep did you love that fetus or that baby growing in your stomach? How deep did you love that baby that you stillbirthed, right? And that you held? That is how deep you are going to grieve. Thank you, Traci. Next slide. Thank you. So I want to talk a little bit more about perinatal mood and anxiety disorders, which we now call PMADs. So back in the day, when I, like Alicia, I am a lived experience as well, right? And back in my day, when I experienced one of my losses, we just talked about postpartum depression disorder. We now know in the clinical world, there is a huge range, right, of disorders that we want to look for, right? And we now call them peri-mood and anxiety disorders. And they can start before conception, right? Because if we're talking about people struggling with infertility, and Traci talked about that cycle of hope and loss, right? Very often see perinatal mood and anxiety disorders, or the same type of disorders. But for the sake of this conversation, we're going to talk about conception through, initially people talk about 1 year after loss, but we actually know that PMADs, really we see it up to 3 years easily after loss. And because it's often just missed, right? And someone has experienced very, very prolonged postpartum depression or postpartum anxiety. So just some numbers that I want to share and give some weight to is approximately 15 to 21% of women and birthing persons are going to, with an uncomplicated pregnancy, an uncomplicated birth, are going to experience perinatal mood and anxiety disorders. And I'll break down a little bit more what those are after. And about 10% of birthing partners, most of the studies say dads or men, right? And we know, luckily, we're working on that as so many more studies need to be done and in the perinatal world and LGBTQ+, but I'm going to have to use the words that we have from the studies that we have, right? So men, dads, up to 10% in uncomplicated pregnancies and birth, right? So, and we know that having a loss or a history of loss increases, right? The experience of perinatal mood and anxiety disorder. So when we're working with someone, or we're with someone that has had a loss or had an experience of loss, we want to know that these numbers are potentially going to be much, much bigger. Studies also show that 30% of people with pregnancy loss experience significant emotional reaction, right? And there isn't well, it was 7 weeks, well, it was 20 weeks. It doesn't matter, right? It is 30% of people with pregnancy losses experience significant emotional reactions, right? That also can turn into disorders or something they need clinical support for. So I want to talk about what are some diagnoses that we might be looking for, like when Traci talked about doing the assessments, right? What these assessments are looking for and why someone might come for clinical support, right? Or psychiatric support with medication, right? So under the perinatal mood and anxiety disorders, we have major depressive disorder, which is often referred to as postpartum depression, but we also know it happens in pregnancy, bipolar disorder, generalized anxiety disorder, obsessive compulsive disorder, postpartum psychosis, PTSD, trauma disorders. There's something that's not under PMADS, but I do also want to briefly talk about prolonged grief disorder, which is very exciting in my world because used to be called complicated grief. And I don't know, for people who've heard of Dr. Catherine Shear out of Columbia, has worked amazingly on this to get this recognized, along with other people by the DSM-5. Used to be called complicated grief. It's now called, it's in the DSM-5, prolonged grief disorder. There's a bunch of symptoms I won't get into, but it starts after a year of prolonged grief. So it doesn't necessarily fall under PMADS, but these are, again, are all things we're look for. I also want to take a moment to talk a little bit about the difference, as we're all sitting here, between postpartum or perinatal obsessive compulsive disorder with intrusive thoughts, or PTSD with intrusive thoughts, versus postpartum psychosis. Because postpartum psychosis is often misdiagnosed by medical providers, by other very, very well-meaning support systems. So I just always want to take a minute here to talk about it. So when someone is experiencing intrusive thoughts and obsessive compulsive disorder, they will often have very disturbing, and they feel disturbing, they're ego dystonic, they don't feel good to you, images, and some people here may have experienced this, of harm coming to your baby, or of even you harming your baby, or of harm coming to yourself. So I have people talk about, I constantly have this image, I'm gonna suffocate my baby when the baby's in the carrier by mistake, right? Or I'm walking down the stairs and I'm gonna trip down the stairs and fall and crush my baby's skull. Or I have these visions, these horrible visions of I'm giving my baby a bath and I'm gonna purposely drown my baby. And it feels so disturbing to that person. That is not postpartum psychosis, because those thoughts feel very, very scary. And then often, so those intrusive thoughts will often then lead to obsessive checking, obsessive care for the baby, right? Things because it doesn't feel good to the person. When we're looking for symptoms of postpartum psychosis, of course, we want to look for delusions, we want to look for hallucinations, but one of the key things, the distinguishing things between these intrusive thoughts is that it feels egosyntonic, it feels good. So someone might say, it feels good, I need to go jump off a roof. It's going to sound really harsh, right? But this is what happens, right? I'm going to take my children and we're all going to jump off the roof because the devil is telling me to, and God is waiting for us as we do. And it doesn't feel disturbing, and it doesn't feel scary, and it feels like a sense of relief, right? That is very different than someone who is often going to be too scared to share this, right? Because people also often come in and they don't want to share these intrusive thoughts that they're having because they're scared someone's going to lock them up or take away their baby, right? And it's always good to do further assessment, right? Do you want to harm your baby? Does that feel good to harm your baby? Do you have a plan? No. I don't want to hurt my baby, and I'm so scared I'm going to, right? So again, thank you for allowing me to take the time just to separate those. And Traci, I know you have experience with this too. If there's anything you want to add on that, feel free.
If you don't mind, Jenna, I just want to make mention, like, as doulas and home visitors, our families may share some of these thoughts, scary thoughts that they're having with us. And it is important to sort of hear what they're saying, validate that these can be normal. But again, not as a clinical person, it's important to make sure we are getting that clinical support in place for them, whether they're obsessive thoughts and scary thoughts, or they're actually, concerns with psychosis. So that's a call that, as home visitors and community health workers and doulas, all of that, we really need to be mindful that either of those things definitely need some clinical interaction and support. Thanks, Jenna.
Thanks, Traci. And so some of the things you might see, right, with depression, right, is not being able to get out of bed, not bonding, struggle, feelings like you were struggling to bond with your baby, right? Chronic racing thoughts of anxiety. We talked about the obsessive compulsive, right? Constantly checking doors or making sure the baby's breathing, or feeling like you constantly calling the midwife or the OBGYN to see if there's a heartbeat, right? These are some of the things that we might see. I'm not going to get into the difference between postpartum depression and baby blues, but that is also another really significant thing. I will just say baby blues is something that happens in the first 2 weeks and is very common. 60 to 80% of birthing people experience baby blues. It's the lack of sleep and fluctuation of hormones and change in life. You can still experience positive thoughts, right? You can have worries, but then you can completely calm yourself down, right? It's very much like this and usually ends after 2 weeks. Whereas postpartum depression, there's anhedonia. Even if you sleep, you don't feel rested. You may feel like your baby would be better off being raised by someone else. So let's talk a little bit about the numbers here. So according to a 2016 study published in the Journal of Women's Health, let's talk about with miscarriage first. There is a great increase of risk for anxiety, which I can tell you from working with lots of people who have experienced miscarriage. There is understandably a huge increase in anxiety. And we also want to note, and Alicia's going to talk about some supports for this too, when she talks about pregnancy after loss, that 50 to 80% of people who've experienced miscarriage will become pregnant again. So that's a lot of people having perinatal anxiety. 22% of those who become pregnant after loss will experience that general anxiety disorder, right? So again, I always say if you're in a room full of 100 people that have had a miscarriage and are pregnant again, 20 of those people are probably going to be having racing anxiety thoughts that you're sitting in the room that are going through their head that they're just not saying out loud. And the same thing, 20% of those will have symptoms of major depression. So that same room of 100 people that are pregnant after experiencing loss, 20 of them may be hiding major depressive disorder, right? Now let's talk about that in terms of stillbirth and neonatal loss. Oh, sorry, Traci, go back one more time to the slide. So people who have experienced stillbirth or neonatal loss are at a 4-time higher risk of depressive symptoms and a 7 times higher risk of PTSD. And also want to note, and again, this goes back to the screenings that Traci talked about. So sometimes the higher levels of depression and PTSD don't even come out until 9 months postpartum. So it's really important that as we work and care for people, that we continue to screen, because we may not see a level high enough to detect until 6 months or 9 months. And also that there is no association between length of gestation and level of distress. So if someone has a miscarriage at 7 weeks versus someone has a miscarriage at 14 weeks, there is no automatic that the person at 14 weeks is going to have more levels of distress, right? It's going to depend on that person and how they experience it and what their history is. All right, Traci, we can go on to the next slide. Okay, so we talked a little bit about signs and symptoms. But it gets really complicated in pregnancy, right, and postpartum, because the typical losses that we look for when we're looking for anxiety, depression, OCD, right, we're looking for changes in functioning. So physical would be eating, changing in eating, sleeping, weight loss, weight gain, physical pain. Obviously, we're going to have that in pregnancy and postpartum, right? So we want to look for what seems to be beyond the norm, right? For those, right? So someone who literally is not sleeping at all or cannot fall asleep at all, not because the baby is kicking or not because of something else, right? But they can't sleep. And they're reporting they can't sleep and they don't know why, right? Change in emotional functioning. Someone who just can't stop crying, right? Or someone who literally can't cry at all because they're completely dissociated. Chronic isolation, chronic feelings of anxiety, depression, and then always thoughts of suicide, thoughts of self-harm, not wanting to live. It is very, very common to hear from someone who's just had a loss, I don't want to live, right? So we really, really want to dig into that. And how long does that go on for, right? Do they have plans? Do they have a means? Do they have an intent? With trauma, right? Looking for signs of trauma, we're talking about flashbacks, a lot of self-blame. I think that came out a lot in a lot of quotes that I read from people. It's my fault. I should have done this. I need to go back and fix it, right? Avoidance of reminders, right? Which is really important as we talk about postpartum care or perinatal care, right? That people don't want to go back to the hospital or back to their OB's office. People are completely unable to talk about the loss or the death, or they can only think about or talk about the loss of the death. So, and obsessive and compulsive behaviors, right? So someone who's having, who thinks that after, so they've had a loss and maybe they are chronically worried that something is going to happen to them, or it happened to an older child that they had, and they're doing chronic behaviors to make themselves feel better, like lock the door or check that their 2-year-old is sleeping, or make sure that their own breathing, that they're breathing themselves. And then we have some more subtle signs, right? Which I talked a little bit of, sort of that feeling stuck, right? I get a lot of people come to me who like, I just feel stuck. I feel like I need to accept this, or I can't move past this, right? Or they don't have any space in their life to grieve, right? To grieve, right? They're expected by their family or by society to move on. Struggle to develop, I talked about the struggle to feel like they've developed a healthy attachment to their next pregnancy. Traci, if you can change the slide. So where does that leave us, right? So what kind of clinical supports are out there? And I'm sure a lot of you out there know this already, but I just listed a few. So there's individual therapy, right? Referring people to individual therapy. There's cognitive behavioral therapy, CBT. There's EMDR, eye movement desensitization and reprocessing. The two above are something that I work with a lot with perinatal clients who have experienced grief. And I did talk a little bit about prolonged grief disorder. There is a very specific therapy which has very good results, which is out of Columbia with Dr. Catherine Shearer. And if you go on their website, there's a specific therapy for prolonged grief disorder, which would work for perinatal loss or other losses. All of these would work for all types of losses. There's also couples therapy, right? Loss for couples can be very, very hard. People experience it differently. There's often the birthing parent and the non-birthing parent, and getting them to experience and validate and communicate and know how to help each other. There's group therapy, right? Group therapy is a huge support because you hear other people talk about what that experience is like, and people don't feel so alone. And it's led by a clinician, right? Who also helps people move through that grief, right? And talk about their grief and create coping skills. And then of course, medication. And that's something I often refer to psychiatry during pregnancy or after pregnancy, right? To work with someone, and there are specialized perinatal psychiatrists who specialize in providing medication for people in reproductive stages. And I think now, Traci, is this you or is this Alicia? I think this is Alicia, right? Okay.
All right. So in addition to the clinical supports and modalities mentioned previously by Jenna and Traci, I'm just going to touch a little bit on the importance and the benefits that community support can provide to those who've suffered a pregnancy and or infant loss. As we mentioned before, I work at Hope After Loss as a social worker and a program manager. Hope After Loss is a nationwide nonprofit based right here in Connecticut, and we're dedicated to supporting the pregnancy and infant loss community. As we said, I'm a person with lived experience, not as somebody who has suffered a pregnancy and infant loss myself, but one whose twin sister died after birth. My experience comes from living as a bereaved sibling in a bereaved family, and now, fortunately, I'm in the position to support others. Now, when we talk about those who have suffered a pregnancy or infant loss, the term community is necessary to this population. So we define community as a unified body of individuals. And although it's a group that no one ever wants to be a part of or sometimes expects to be a part of, the establishment of this community is necessary due to the societal hush that's been imposed on these members over the years. Traci, can you hit the next slide? Thank you. So when observing the figure below, we see that someone who's experienced a pregnancy or infant loss can feel, confusion, pain, isolation, stigmatization, grief, depression, anxiety, pressure, and a loss of identity. And these feelings are typical in grief and are often exacerbated when the societal norm expects those who have had a loss to suffer in silence. The taboo nature of pregnancy and infant loss can be traced back decades, and only recently we've seen relief in the media and in supports. For those decades, those who have experienced this form of loss were expected to suffer in silence, forget their loss, and wear a smile on their face for family, friends, coworkers, and society to appease them. And this is where, we come into the thought of, even though, supporting someone who has had a loss might be uncomfortable for us, that doesn't matter because we're there for them. This is where the role of community comes into play. So in the turn of the 21st century, we start to see groups, organizations, and alliances form to provide a space for lost parents to connect and speak of their experiences with each other. They gain tools, vocabulary, and strength to then start to speak of their own experience with others in their lives. And although there's been great strides that have been made in reducing the stigma of pregnancy and infant loss, there is really still more room for advancement. And the disconnection between perinatal grief and societal support is why Hope After Loss exists. You can hit the next slide. So at Hope After Loss, we help those who experience pregnancy and infant loss to find the inspiration of hope by providing connections, comfort, and care. So our participants are mainly composed of hundreds of lost parents across the country, each with a different story, a different experience of loss, different personal support levels, and different backgrounds. Although, everybody does have, their own unique experience, they do all have at least one thing in common, and that's that they have found community within each other. The community that they do find can be seen throughout our organization. In our beliefs, we state that we're committed to ensuring that nobody who has lost a baby has to grieve alone. And that's something that we stand by through all of our supports. Losing a much wanted baby can feel basically like being plunged into darkness, and finding your way out of that isn't easy. But it's made easier when others extend their hands to help. And we call this our peer support model. So how is peer support different? So the first is that there is a less expectation to be, okay. We don't have to put on that smiling mask when we go out into the world. Many participants, especially those who, are newer to Hope After Loss or have recently experienced a loss, find it daunting to talk about their experience because they're afraid that they're not going to be able to be strong. I personally have had this conversation, I don't even know how many times, when I'm on the phone with somebody new who's looking to seek services. And I always have to remind them that, in this space, they don't need to be strong and that it's okay not to be okay. And although this sentiment is usually met with tears, there's a component, between the breaths of like those heavy sobs that is a space of relief. Relief that they found somewhere that others understand their feelings and that there's no need to mask their emotions or hide their thoughts anymore. And then there's decreased feelings of clinical judgment. So although clinical intervention is often imperative and beneficial to those needing support, there's also sometimes concern that clinicians are going to label them as crazy or irrational or place them in inpatient care when it's not warranted. Not everybody has a Jenna, and sometimes clinical providers are not as informed as they should be on pregnancy and infant loss. The majority of these worries do not stem from clinicians or from the mental health system as a whole, rather the stigma from society telling them that their feelings are crazy, or that they don't need to be grieving as hard as they are. The next is shared experiences of grief and loss. So participants, facilitators, staff, board members, and other organization supporters share their experiences of pregnancy and infant loss with each other. And in turn, that they grieve with each other and for one another. I find it, beautiful and heartbreaking when, I get messages saying like, oh, I found another participant online and they texted me, on my due date. Or that they remembered my baby's name or something special or a symbol that reminds me of them and that they saw it in the world and just sent it to me. There's something so special about that. And, in order to maintain safe boundaries and privacy, clinicians don't always share, personally if they have had a loss. And although it's, totally for the well-being of the patient and integrity of their care, many patients have recounted that they feel connected to, one another and to Hope After Loss members through shared stories of loss. And In this way, they're able to speak their baby's names, hear their baby's names being said by others, and are able to remember special days and grieve hard days together. Another is that there's a cathartic experience of supporting others. So this stems from, support group participants who become facilitators, participants who volunteer their time to Hope After Loss, and those who create fundraising teams for Hope After Loss or events. Many feel a sense of belonging, purpose, and catharsis by being able to support another lost parent, and knowing that, there is some support that they're able to share out of such a dark experience. The next is decreased feelings of isolation. This is just, through connections within the community that become made. There's opportunity to remember all special babies that are gone too soon in a safe place, and that others will understand what you're feeling and those scary thoughts that you do have. There's also support outside of traditional office hours. So our peer support operates in the evenings after most clinicians are done practicing for the day if they don't have evening hours. And this allows those who are in clinical treatment to receive additional support for the day, and those who aren't involved in clinical treatment to have a space at the end of the day for release. And it's also really beneficial as a step down or step up to clinical intervention. So support groups and individual peer support are a great tool to introduce, support into their life, or as a gradual step down from clinical intervention as a whole. You can go to the next one, Traci. So this is our support model. So new participants join our support groups, and this can be following a recent loss or a need to grieve a more distant loss. I've had referrals for a birthing person who has had a loss 30 years ago, and is just seeing the shift in the world where they realize, like, hey, I never grieved this, or I didn't feel like I was allowed to, and here's this space that's a breath of fresh air. Participants can join us from self-referrals or referrals from clinical providers, hospital staff, family friends, and sometimes funeral workers. Support groups are open, and they're composed of new and older lost parents at varying stages of grief. Many have attended regularly for years, and there's no timeline or motivation for them to ever not need Hope After Loss. We remain open for anybody who needs support at any time for any reason. Bereaved parents who have attended prior support groups and have completed the Hope After Loss training then become facilitators, and many take this way as a cathartic step to support others in groups and individually, as well as to honor their losses. Recently, I trained one bereaved father, and he's just amazing. And during the training, I had asked him, what prompted him to want to, become a facilitator. He just had suffered a stillbirth of his daughter the year prior. And what he said to me was, I will absolutely never forget it. And he said that my wife and I are expecting another baby, and she was getting induced in just 2 weeks. And he said, I know this time is going to be hectic and I'm going to be so busy, but I want to do this. I want to help other people because it's my way to tell my daughter that I lost, that I haven't forgot about her and that I never will. And she's going to be my motivation to help all of these families. And that he's done just that. Facilitators often recount their own losses and support those who are starting their own grief journey. And this creates a connection and sets the tone for the group for individual support, and that it's okay to remember and it's okay to grieve. Returning participants can choose then to become trained to help others who have suffered a loss and become facilitators, and the cycle continues. And that's how we provide our peer support. Right, so what's gained from peer support? So we have connections to listen to each other, to their loss, and to their loved ones. There's remembrance opportunities. We provide safe spaces to remember their loss with people who understand and share some similar sentiments. Oftentimes, participants learn coping strategies from other lost parents within the group, learning what they found helpful for different scenarios in their grief and life. There's a group process of troubling scenarios. One that I heard recently was that one of our participants was saying that she desperately needed to get her hair dyed again, but that she didn't want to go back to her hairstylist because her hairstylist is pregnant, and she didn't want to see, and talk about, her pregnancy, and she didn't know how to celebrate with that joy that her hairstylist had with her, while also, grieving her own loss. And so the group, together brainstormed some, solutions of what she could do, what they found helpful when having to, communicate with other pregnant people in their life. There's reduction of isolation, just creating those connections. And then there's self-advocacy and self-awareness, which is something that I find so powerful. So in a lot of participants, in understanding their feelings and needs, they learn how to share these needs with others in their life outside of Hope After Loss, and advocate for what they need to feel supported by those outside of the pregnancy and infant loss community. And that's so important to be able to get to, the space where you can tell your mom, like, hey, that's not exactly, a helpful thing to say, or this is what I need from you. Traci, could you just hit the next slide, please? Thank you. So in joining peer support and clinical intervention, it does not need to be an either or, rather it can be a hand-in-hand approach. Between the two, there are three main components that can be seen in both. And those are the ability to hold space, process grief, and create connection. So within Hope After Loss, we're here to be in this overlap between the two and support bereaved parents as well as clinicians through our free community support programs, education for clinicians, and increasing awareness and advocating for the needs of the pregnancy and infant loss community all the while.
So Alicia, did you want to talk about some resources, or did you want,
Sure, you can go ahead and take on these resources, and I'll chime in where I have some info.
Great, because I know you have so much. So we just wanted to sort of give you all some tangible resources to access. So when you get the PowerPoint, you'll have all of these for your own toolkit, so to speak. Finding clinical resources, Psychology Today, the Center for Prolonged Grief, and the EMDR, to learn more about that training and certification process. The websites are here.
Just a note on Psychology Today, this is one of the major resources that I do give to people who are looking for clinical intervention. Something that I find very helpful about this website is that you can filter the results by insurance type, by location, by modality. And there's also people, they list their, specialties on the side, and you can always, scan to see if they've had, experience working with people who've had a pregnancy or infant loss.
These are just a few of our Connecticut resources. Obviously, Alicia's program, Hope After Loss, is just a huge support. There's also Postpartum Support International, and I have a slide coming up that just demonstrates more about the ongoing sort of different types of supports and groups that they offer. Access Mental Health for Moms is, I'm sure a lot of you are already familiar, but I like to mention it because it's on the newer side of things, but it's a real-time support for clinical consultation for providers that are working with, with families that are in the perinatal period, if there's any concern. And then Jenna's program, Child and Family Agency of Southeastern Connecticut, with her area of expertise in perinatal grief and loss. This is the Postpartum Support International slide. I just wanted to show you they literally have a whole lot of different groups available for all different types of, not just perinatal grief and loss, but all different types of things related to the maternity period. And then these are just some more resources that you guys can all explore if you find that you need to. And Jenna, did you want to talk for a moment about?
Yeah, I know we're tight on time, so I'll just talk briefly for it. So for all of us in this room, right, working with people who have experienced trauma, experienced loss, we're very likely to experience secondary trauma, compassion fatigue, burnout, right? How do we find time for self-care, and what does that look like, right? Are you aware of your own warning signs for when you need support, when you're burnt out, or when you're taking on someone else's trauma? Are you consulting with other peers and professionals? So those same resources that we put up for other people, right? So can be used by any one of us in here, right? Who's looking to find their own support, because we have to make sure that we're supported as we support other people and help carry their pain and help carry them loss and help them work through it.
Thanks, Jenna. So I wanted to leave you all with our contact information